Welcome to the deep dive.
Great to be here.
Today we are tackling a system that touches every single one of us, the U.S. healthcare system.
It really does.
We've gathered quite a collection of analysis, really trying to get under the skin of how it's structured, how it's funded, the challenges it faces, and maybe some potential ways forward.
Yeah.
Our mission, basically, is to take all this complex information and distill it down into something clear, something understandable for you.
And what just leaps out immediately from all this data is this striking paradox. The U.S. spends, well, vastly more on healthcare than any other high-income country.
Right. Way more.
But the health outcomes we actually get, often worse.
Yeah.
And definitely less equitable.
Yeah.
That kind of fundamental disconnect, that's what we really want to dig into today.
It really makes you wonder, doesn't it? Where is all that money going? And why aren't we seeing, healthier lives as a result?
Exactly.
We've got some detailed info here, covers the basic structure, the complex financing, all the key players.
And they're often competing interests. That's key.
Right. And how we stack up internationally, performance-wise, plus some thinking on how we might make it work better for everyone.
Yeah, potential reforms.
Okay, so let's start with the landscape, the basic shape of U.S. healthcare. What are its kind of defining features?
Well, the most distinctive thing is probably its mixed payer model.
Mixed payer.
Yeah, unlike most other wealthy nations, they've mostly moved towards more unified, universal systems. The U.S., we operate with this blend of public programs, think Medicare, Medicaid, right alongside a very large private insurance sector.
It's definitely unique.
It is. And interestingly, looking at the data, that mix doesn't automatically mean better results compared to other countries.
No, it seems not. And diving into these sources, this unique approach seems to create some, inherent tensions.
Definitely.
You've got these huge publicly traded insurance companies, pharmaceutical firms. Their main duty is to their stockholders, right?
Primarily, yes. Maximizing shareholder wealth.
So how does that line up with the bigger societal goal of affordable, accessible, high-quality care, not to mention the doctor's duty to the patient?
That's a really critical point, the potential conflict.
Yeah.
It's huge. The drive for profit versus the goals of patient health and fair access.
It seems to run through everything.
It really does.
Oh.
It affects how care is paid for, how drugs are priced. If you look at the big picture, this dynamic is a major contributor to, a lot of the challenges we're going to talk about.
And it's not just public versus private. The whole system seems incredibly fragmented.
Oh, absolutely.
We're talking, tons of different insurers, different regulators at state and federal levels, a real patchwork of how care is actually delivered.
Right.
How does all that complexity hit someone just, trying to see a doctor?
Well, the fragmentation is a massive hurdle. It really hurts efficiency.
Okay.
It makes coordinating care, which is so vital, especially if you have chronic conditions, really, really difficult.
I can imagine.
And it definitely makes the existing inequalities worse. Think about trying to use any service where the rules change almost every time you interact with it.
Yeah, that sounds exhausting.
That's often the reality. And this complexity, it makes setting consistent national health policies incredibly tough. So, what looks like choice can actually mean a system that's harder for you to navigate.
Now, the government's role in all this, it feels like a constant tug of war. The sources call it an evolving American story, lots of historical compromises. We have Medicare and Medicaid, huge programs, but also this deeply rooted private market. It doesn't feel like there's a settled national agreement on how much the government should actually do.
That lack of consensus is fundamental. It really helps explain why reforms have often been piecemeal,
Right.
And why we keep having these debates about, say, expanding the ACA or bringing in a public option.
Yeah.
These debates often reflect really different core beliefs about healthcare. Is it a right? Is it a commodity?
And without that shared vision.
Without that shared vision, big systemic change is just incredibly difficult to pull off.
Okay, so who are the main players in this complicated setup? Let's break down their roles, how they interact. Patients, obviously, are central, or should be. What's their role besides just getting care?
Well, ideally, patients are more than just recipients. They're active participants in their own health, making informed decisions.
Okay.
And they're also taxpayers. They're voters. So collectively, their voices can shape policy. But the system's complexity often makes it really hard for individuals to be truly informed decision makers.
Then you've got physicians, the ones on the front lines. They have this, ethical duty to patients.
Absolutely, a fiduciary duty.
But they're stuck working within this system with all its pressures.
That's right. Doctors often find themselves juggling insurance company demands like prior authorizations while trying to do what's best for the patient.
That sounds stressful.
It is. It creates ethical dilemmas. It contributes to burnout. It really makes you ask, how can we align the system's pressures better with the patient's best interests?
Good question. Employers are another huge piece. They provide insurance for, like half the non-elderly population?
Roughly, yes. It's the most common way people under 65 get coverage.
But it's not their main business, right? They're just providing it as a benefit. Yet they're huge buyers of healthcare influencing plan designs.
That's a key point. For most employers, it's a major cost, not a profit center. And it's a cost that keeps going up.
Yeah.
So their decisions about plans, about how much employees have to chip in, that directly impacts millions of people's access and affordability.
Raises the question, is the employer model sustainable long-term?
That's a very active debate, especially with costs rising the way they are.
Okay, then the insurance companies themselves, selling coverage, managing money. But like we said, their first duty is often to shareholders.
Exactly. They do necessary things, like manage risk, process claims. But that goal of maximizing shareholder value, it can sometimes lead to practices that limit access or increase costs, like tight underwriting or managing benefits really aggressively.
And the pharmaceutical companies, big R&D, manufacturing, but also profit-driven, which massively impacts drug prices. That's a huge part of spending, isn't it?
A huge part. And it highlights that delicate balance, doesn't it? How do you incentivize the innovation we need?
Right, the new drugs.
Which companies say requires profit, while also making sure essential medicines are actually affordable for the people who need them. High U.S. drug prices are a perfect example of that conflict.
And finally, the government. It pays for seniors, people with disabilities, lower-income folks through Medicare and Medicaid.
Right.
It's also a regulator, funds research, even provides care directly through the VA. But like we noted, there's this constant debate about how big its role should be.
Its role is definitely multifaceted, payer, regulator, researcher. And the debate continues because it touches on those fundamental questions about healthcare and government responsibility.
And within the government, it's like alphabet soup: HHS, CMS, CDC, FDA, NIH, AHRQ, PCRI.
Oh, yeah, it can feel that way.
What are the main ones we should keep in mind?
Okay, think of HHS, Health and Human Services, as the big umbrella.
Got it.
CMS, Centers for Medicare and Medicaid Services, is the huge payer, running those programs plus the ACA marketplaces.
Okay.
CDC is public health, disease prevention. FDA checks safety for drugs, food, medical devices. NIH funds the bulk of medical research.
Right.
AHRQ focuses on healthcare quality and safety research. And PCRI looks at what treatments work best in the real world for patients. Each has a really distinct vital role.
Okay, that helps clarify it a bit. Let's switch gears to the money side. Financing this massive system, those trillions of dollars. Let's dig into national health expenditures, or NHE.
Yeah, prepare for some pretty mind-boggling numbers here.
Okay.
In 2023, the U.S. spent around $4.9 trillion on healthcare.
Trillion. Wow.
Which works out to about $14,570 for every person.
Per person.
And it's a massive chunk of our economy, 17.6% of GDP.
Almost a fifth of everything we produce.
Exactly. And what's really striking is how fast it's growing. It jumped 7.5% just from 2022.
Yeah.
That's faster than the overall economy grew.
That seems problematic. And our sources show this isn't new, right? It's tripled since 2000. Went from 5% of GDP in 1960 to nearly 18% now.
That trajectory is just, well, it's widely seen as unsustainable.
Yeah.
Think about the pressure that puts on government budgets, federal, state, local, on businesses trying to offer benefits and compete, and on individuals, families.
Just trying to pay the bills.
Right. It impacts everything, our economic competitiveness, household financial security. It really begs the question, what are the long-term consequences if this keeps up?
So who's footing this nearly $5 trillion bill? Where did the money come from in 2023?
Okay, so if you lump government insurance together, Medicare and Medicaid, mainly that's the biggest chunk, about 45% of the total.
Almost half.
Yeah, around $2.1 trillion. Medicare is about 22%, Medicaid 20%.
Okay.
Private health insurance is the next biggest piece, actually the largest single source. It's 32%, or $1.5 trillion.
Still huge.
And then you have what people pay directly out of their own pockets. Deductibles, co-pays, things insurance doesn't cover. That's a surprisingly big slice, 23%. or $1.1 trillion.
23% out of pocket. That seems really high, especially since most people have insurance, right? It points to that underinsurance issue.
Exactly. Having insurance doesn't always mean you're protected financially. Those out-of-pocket costs averaged, $4,425 per person back in 2022.
That's a lot for many families.
It absolutely is. And it's a major reason for medical debt and why people sometimes avoid getting care they need. Cost becomes a barrier.
The sources also mentioned a trend. The government share of funding is growing, projected to be almost half by 2032, while private insurance might shrink a bit.
Yeah, that trend reflects a few things. Our aging population using more Medicare, policy choices around public programs.
Okay.
But it definitely increases the financial strain on public budgets. And it fuels that ongoing debate about the right public-private mix and, frankly, about the long-term financial health of Medicare and Medicaid.
So how does the money actually flow to the providers? Hospitals, doctors? What are the payment mechanisms?
It varies. For
Okay.
hospitals, when a patient is admitted, it's often paid through the DRG system, diagnosis-related accrued.
Deferred choice.
Yeah, it's a prospective payment. The hospital gets a fixed amount based on the diagnosis, kind of regardless of the exact services used.
Okay. A set price for a condition.
Pretty much. For outpatient hospital services, it's often different, more like fee-for-service, using something called APCs.
And doctors.
Doctors are generally paid fee-for-service.
Mm-hmm.
They bill using specific codes, CPT codes, for every single thing they do, and that's billed separately from the hospital charges.
Do these different payment methods cause any issues or unintended effects?
Oh, definitely. Fee-for-service fundamentally can incentivize doing more things, more volume, not necessarily better quality care or outcomes.
Right. Get paid for each procedure.
Exactly. And even with DRGs for hospitals, while they aim to control costs, there's potential for things like upcoding, classifying a case as more complex to get a higher payment. And a really big issue is the difference in what payers pay. Private insurers often pay hospitals well above the cost of care,
Okay.
while Medicare and Medicaid often pay less than cost.
So hospitals lose money on them.
They often do, which leads to cost shifting. Hospitals try to make up the difference by charging private plans more.
Which then drives up private insurance premiums.
Exactly. It's this complex web of incentives and cross-subsidies.
Clearly. Okay, let's zoom in on the main coverage programs themselves. Private insurance, first, employer-sponsored is the big one, but there's also the individual market.
Right. Employer-sponsored insurance, ESI, still covers the most non-elderly folks. But it's under pressure. Premiums are way up. Workers are paying a bigger slice of that premium.
Yeah, I hear about that a lot.
It's forcing employers to look at alternatives, and it's definitely squeezing budgets for companies and employees.
And the individual market, like the ACA marketplaces.
That market's grown, valued at, $1.6 trillion in 2022. More insurers are participating. But affordability is still a major challenge if you don't qualify for subsidies.
Right. So even with the ACA, it can be tough.
It can be. Ensuring that coverage is truly affordable remains a work in progress.
Okay, on to the public programs. Medicare federal program for 65 plus, some younger folks with disabilities. It's got different parts, A, B, C, D.
Medicare is absolutely foundational, covers over 65 million people. Part A is hospitals, Part B is doctors and outpatient stuff. Part C is Medicare Advantage private plans. And Part D is prescription drugs.
Huge program.
Massive. Pays for about 22% of all healthcare spending. And its projected growth. That raises serious questions about long-term financial stability.
Then there's Medicaid, joint federal state for low-income people. Biggest safety net, over 80 million covered, but it varies a lot by state.
That's a key feature. The federal government sets basic rules, but states run it. They decide exact eligibility, benefits, how much they pay doctors and hospitals.
And the ACA expansion.
The ACA lets states expand Medicaid to cover more low-income adults, up to 138% of the poverty line. Big deal. But not all states did it.
Creating that coverage gap we hear about.
Exactly. People too poor for ACA subsidies, but living in a state that didn't expand Medicaid, so they don't qualify for that either. Stuck in the middle with no affordable option.
Wow. But for those who qualify, Medicaid offers pretty broad benefits.
Generally, yes. Covers doctor visits, hospital stays, often crucial long-term care services. But again, access can really vary depending on your state's policies and payment rates. And like Medicare, its spending is projected to climb significantly.
What about CHIP, Children's Health Insurance Program? That's also a federal state.
Right. CHIP targets kids and families who earn too much for Medicaid but can't really afford private insurance.
Kind of bridges the gap for kids.
Exactly. It's designed to be affordable, Often free checkups, limits on premiums and copays. It's super important for making sure millions of kids get needed care, preventive stuff, which is huge for their future health.
And finally, the VA system. Veterans Health Administration, totally different model, right? Government-run, integrated.
Completely different. It's the largest integrated healthcare network in the country, serving about 9 million veterans a year. Comprehensive services, often tailored to veteran-specific needs. Eligibility depends on service history, priority for service-connected issues. It's a unique model within the U.S.
So looking at all these pieces together, private plans, Medicare, Medicaid, CHIP, VA, the word that keeps coming up is patchwork.
It really is a patchwork, not a unified system.
And that leads to problems.
Oh yeah. Complexities, gaps, people falling through the cracks between programs, eligibility cliffs where a small raise makes you lose coverage, huge administrative burden trying to manage it all.
And inequities.
Absolutely. It makes existing inequities worse. And the underlying issue, rising costs across all these different parts. It's not just one program's problem. The growing financial role of the public programs just makes sustainability a huge policy headache.
Okay, we've mapped out the landscape structure, money, programs. Now the big question, how well does it actually work? Performance and the major challenges. Let's start comparing the U.S. internationally.
Right. When you put the U.S. system side by side with other high-income countries,
Sure.
the results are pretty sobering.
How so? Spending first.
Spending, we're off the charts. Way more per person, way bigger slice of our GDP, nearly 18% in 2021 versus maybe 9–10% for the average wealthy nation. Almost double what Germany spends per person.
Double. Okay, but do we get better health for all that money?
Generally, no. That's the paradox. Our life expectancy, among the lowest in that group, rates of avoidable deaths, the highest, nearly double the premature death rate compared to peer nations in 2021.
That's shocking.
Infant mortality, maternal mortality, highest among wealthy nations. Chronic conditions, obesity, highest rates there too.
So it's a huge value deficit, as the sources call it. Spending loads, getting poor results.
Exactly. It suggests the problem isn't lack of money, it's the flawed structure of the system itself. Needs systemic reform focused on efficiency, equity, quality.
What about just getting access to care? How do we compare there?
Access is another major concern internationally. We're unique among wealthy nations for not having universal coverage. Millions uninsured.
Right.
And Americans actually see doctors less often than people in most peer countries.
Yeah.
Could be cost, lack of a regular doctor, maybe fewer doctors in some area.
Fewer hospital beds, too.
Fewer beds per capita than the OECD average, yeah. So lack of coverage, barriers to access, it leads to delayed care, unmet needs, and ultimately worse outcomes.
Oh, and administrative efficiency, all that complexity we talked about.
We perform poorly there too. Ranked near the bottom 9th out of 10 in a recent Commonwealth Fund report.
Why so bad?
Largely blamed on the multi-payer complexity. All the different billing rules, claims processing, prior authorizations. It creates massive administrative costs that don't actually help patients get better.
Just overhead.
A lot of it, yes, compared to more streamlined systems.
And finally, equity, fairness across the population.
Again, near the bottom internationally. Big gaps in access and affordability based on income, race, ethnicity, where you live. Huge disparities.
So the system doesn't distribute its burdens and benefits fairly.
Not even close. Vulnerable groups face the biggest hurdles. It's a systemic failure needing reforms that target coverage, affordability even for the insured, and those underlying social determinants of health.
Okay, so performance issues are clear. Let's dig into the key challenges driving this. High and rising costs seems like the evergreen problem.
It really is. We are just such an outlier on spending, and it keeps climbing. Personal healthcare spending jumped 9.4% in 2023, biggest increase since 1990.
Wow. What's driving that?
Main drivers recently were drugs up over 11% and hospital costs up over 10%.
And underlying factors.
High prices for basically everything, services, drugs, devices, the administrative complexity we just mentioned. And we tend to use a lot of expensive technology, not always with proof of better outcomes.
And the impact.
Massive financial strain. Governments, businesses, it affects their competitiveness, holds down wages. Individuals, medical debt, wiping out savings, people skipping needed care. It's a huge burden.
Barriers to access and coverage are another big one. We still have millions uninsured, right? Even after the ACA.
Yeah, about 9.5% under 65 were uninsured in 2023. That's over 25 million people.
Who are they, mostly?
Mostly in low-income families. Many actually have jobs. Big disparities, too much higher rates for Hispanic and Native American populations. And rates are higher in states that didn't expand Medicaid.
And why are they uninsured?
Top reason, cost. Just too expensive.
And then there's the underinsurance crisis. People with insurance but still facing huge costs.
Exactly. High deductibles, high copays. The insurance doesn't provide enough financial protection. Nearly half of U.S. adults say they've had problems paying for care or skipped it due to cost.
Half. That's staggering. And not just low-income people.
Even higher-income Americans struggle more with healthcare costs than low-income people in other developed countries. It affects everyone.
Quality concerns and inefficiencies, too. Spending all this money, lagging outcomes, administrative waste.
Right. The outcome gap is stark. And the administrative waste. Estimates vary, but some say admin costs could be up to 40% of spending, maybe 25% of all spending is wasteful.
Wasteful how?
Unnecessary procedures, administrative complexity, fraud, poor coordination. The U.S. spends way more per person just on admin, like $1,055 versus $306 in Germany.
And that impacts patients and doctors.
Hugely. Patients waste time, face emotional tolls, maybe delay care, dealing with paperwork. Doctors get frustrated, burned out. They spend almost twice as much time on desk work as actually seeing patients. It points to structural flaws, fragmentation, misaligned incentives.
And the fragmented care itself. Lack of coordination.
Big problem. Multiple payers, multiple providers. It often leads to poor coordination, especially for people with complex or chronic illnesses.
Resulting in
duplication of tests, medical errors, gaps in care, higher costs, and just a worse experience for the patient.
Then the pervasive health disparities, these preventable differences linked to social disadvantage. It feels deeply wrong.
It's a profound moral and ethical issue, especially given U.S. resources. Minority groups consistently get lower quality care, less routine care, face higher rates of illness and earlier death. Black infant mortality is 2.5 times that of white infants. Black life expectancy is shorter. Higher rates of chronic diseases like diabetes and hypertension in minority populations.
What causes these gaps?
It's complex. Cost barriers, access issues, bias both conscious and unconscious within the system and society. Addressing it needs really comprehensive reform.
And finally, the impact of social determinants of health, SDOH, where people live, learn, work.
Absolutely crucial. These conditions, economic stability, education, neighborhood safety, access to healthy food, social connections, they often have a bigger impact on health than genetics or even healthcare access itself.
Really bigger.
The evidence suggests so. Poverty is strongly linked to poor health, premature death. Systemic racism creates inequities in housing, education, jobs, all increasing health risks.
And this plays out across life.
Definitely. Lower-income seniors have more disability, die earlier. Social isolation is a risk factor for dementia. Low health literacy makes it hard to make good health decisions. Rural areas face access challenges, high out-of-pocket costs.
So SDOH act like a root cause multiplier.
That's a good way to put it. They amplify other system problems, especially disparities. It shows that just fixing clinical care isn't enough. We need broader cross-sector work.
Wow, it's a daunting list of challenges. So, given all that, what are the pathways forward? How could we get to a higher performing system? Are there guiding principles for reform?
Yeah, any serious reform needs to be grounded in some core principles. First, universal coverage. Everyone gets access to defined, comprehensive services.
Okay. Essential.
Second, affordability. Services and insurance have to be financially accessible, protection from catastrophic costs, medical debt.
Okay.
Third, equity. Eliminate those disparities based on race, income, geography, etc.
Critical.
A fourth, quality. Care must be safe, effective, patient-centered, timely, efficient, and equitable. That last one's key.
And fifth,
efficiency. Optimize resources, cut waste, make sure the money we spend actually translates into better health.
Okay, foundational principles. How do we actually expand coverage and make it affordable? Strengthening the ACA seems like one path.
It's definitely one approach. Making the enhanced marketplace subsidies permanent or boosting them more. That's crucial. They're set to expire end of 2025, which could mean millions lose coverage if nothing's done.
Right. And the Medicaid coverage gap.
That needs a federal fix. Maybe a federal Medicaid-like program for people in that gap, or letting them enroll in marketplace plans with full subsidies. This contrasts sharply with proposals to cut Medicaid funding or add work requirements. Those would just make the gaps worse.
What about a public option, a government-run plan competing with private ones?
That's been debated a lot. Design is key. Would it be based on Medicare? What benefits? How do you avoid only sick people signing up?
Potential upsides.
Proponents say more competition, lower premiums, lower costs overall.
Downsides. Critics worry.
Critics worry private insurers might leave the market, limiting choice. Or that provider payment rates would be too low, become unsustainable.
Have states tried this?
A couple, like Washington and Colorado. Their experiences show it's challenging to significantly lower premiums or get enough doctors to participate. Lessons learned there.
And the most fundamental shift, single payer, like Medicare for all.
That's the big one. Cost and financing are huge questions. The CBO projects massive increases in federal spending, needing new taxes or big cuts elsewhere.
But would overall national spending go up or down?
Depends entirely on the design details. Could go either way.
Access and quality under single payer.
Could definitely achieve universal coverage, reduce out-of-pocket costs, improve access for many. But concerns exist about increased demand leading to wait times, or lower provider rates affecting supply or quality. It's heavily debated.
And politically feasible.
Tough. Initial public support often drops when people consider trade-offs like taxes or potential delays. The political, economic, logistical hurdles are immense. There's no broad consensus for it right now.
So, no silver bullet. It seems like it involves federal and state working together, maybe trying different things. And affordability isn't just premiums, it's the deductibles, co-pays, drug costs.
Exactly. It's multifaceted. Progress is likely to be iterative, maybe combining different approaches. Learning from experiments might be the most pragmatic way forward.
Okay, let's talk controlling costs and getting more value for the money spent. Value-based care or VBC models seem key here.
Absolutely. Moving away from fee-for-service, paying for volume towards VBC, which rewards quality, efficiency, good outcomes. That's a crucial shift.
What are the hoped-for benefits?
Better patient outcomes through better coordination, more prevention, happier patients, and lower costs, fewer unnecessary tests, procedures, hospital stays.
The benefits for doctors, too.
Potentially. More focus on meaningful care, less admin stress from FFS billing, maybe more predictable income.
Examples of VBC.
Things like accountable care organizations, ACOs, bundled payments for, say, a knee replacement, capitated payments where providers get a set amount per patient per month. CMS wants most Medicare, Medicaid folks in these kinds of arrangements by 2030.
Does this need better tech?
Oh, completely.
Yeah.
Robust health IT is essential. Data analytics, EHRs that can actually talk to each other, tools to manage the health of whole populations. You need that to track outcomes, coordinate, see who's performing well. Investing in HIT is foundational for VBC.
Drug price is such a huge cost driver. The Inflation Reduction Act, IRA, lets Medicare negotiate some prices now, right?
Yes, for certain high-cost drugs without generic or biosimilar competition. A big change. First round of negotiations started in 2024. Prices take effect in 2026. More drugs will be added over time.
Controversial, though.
Very. Pharma companies worry it will hurt R&D for new drugs, though the evidence on that is mixed. There are debates about which drugs are included, the timelines, this pill penalty idea where small molecule drugs might be negotiated sooner than biologics. And there are lawsuits ongoing.
So it's about finding that balance.
Exactly. Balancing affordable access with incentives for innovation. It needs careful tuning and watching how it plays out.
Reducing administrative burden, that seems like low-hanging fruit for savings.
You'd think so. Admin costs are incredibly high. Simplifying things could save a lot and free up doctors' time. CMS has initiatives. There's the Paperwork Reduction Act.
It works.
Things like making benefits opt-out instead of opt-in, using existing data to check eligibility, simpler forms, better help for people navigating the system.
Real savings potential.
Huge. One estimate put billing insurance admin costs at $68,000 per doctor per year. Imagine freeing that up for patient care.
But it needs everyone on board.
Yes. Public and private payers working together, more standardization in billing, data sharing, prior authorization. It needs a broader effort.
Okay, so coverage costs. What about improving actual quality and health outcomes? Strengthening primary and preventive care seems fundamental.
It really is.
Yeah.
Good primary care is the bedrock of high-performing systems everywhere. Better outcomes, lower costs, fewer disparities, but it's historically been undervalued in the U.S.
The ACA helped with prevention.
Yes, making many preventive services free, no copay, led to more people getting screenings, vaccines, contraception. Huge positive impact. Removing cost barriers works.
So future reforms should invest more in primary care?
Definitely. Pay primary care providers adequately, support models that allow for comprehensive, coordinated, team-based care, better chronic disease management, catching problems early, managing chronic conditions well. That prevents bigger, costlier issues later.
And health information technology, HIT, potential is huge, but challenges remain.
Exactly. HIT can modernize care, improve coordination, support VBC, boost research. The High-Tech Act got EHRs widely adopted.
Benefits.
More efficiency, fewer errors, better info sharing, decision support, maybe lower costs through better billing.
But the downsides?
High costs. Systems often don't talk to each other, lack of interoperability. And EHRs can be clunky, actually adding to doctor burnout sometimes.
So the focus now is
Optimizing how we use HIT. Achieving real interoperability, making systems user-friendly, making sure they support VBC data needs effectively.
enhancing care coordination and integration vital in our fragmented system, especially for complex patients.
Absolutely. Poor coordination leads to errors, duplication, frustration. Better coordination means a better patient experience, fewer mistakes, better follow-up.
How to improve it?
VBC models like ACOs and medical homes emphasize it. Strong primary care acting as the hub. Reforms need to support communication between providers, use HIT for sharing info, provide resources for care managers or navigators.
Finally, let's circle back to equity. Advancing health equity, tackling disparities, targeted interventions are needed.
Yes. The AMA suggests things like raising awareness of disparities, improving patient-doctor relationships in public plans, ensuring equal protections in managed care.
And the workforce.
Increasing the number of minority healthcare professionals is key, building trust, improving culturally competent care.
And addressing those social determinants of health, SDOH, going beyond clinical care.
Crucial. Recognizing health is shaped by environment. Healthy People 2030 aims to create health-promoting environments.
Examples of what works?
Community-based programs like CDC REACH, policies like earned income tax credits, early childhood education investments, housing programs, better public transport, even water fluoridation. It needs a health in all policies mindset collaboration across government and communities.
Can healthcare systems help?
They can screen for social needs, food insecurity, housing issues, and connect patients to resources. But they need support and infrastructure to do that well.
And promoting culturally competent care and health literacy within the system.
Essential. Meeting patients' social, cultural, linguistic needs interpreters, tailored communication. And health literacy, helping people understand health info to make decisions. Using plain language, teach-back methods.
Needs training.
Training for providers, diversifying the workforce, really focusing on patient-centered communication.
Lastly, strengthening public health infrastructure. Seems vital but often overlooked.
Critically important and chronically underfunded. Public health handles population-level prevention, promotion, disease surveillance, emergency readiness.
Needs sustained investment.
Yes, in core capabilities. Data systems, skilled workforce, preparedness at federal, state, and local levels. Funding is often unstable, reactive. We need consistent, adequate, flexible funding for long-term security against ongoing and new threats.
And public health and clinical care are linked.
Totally interdependent. Strong public health prevents disease, manages outbreaks, which reduces the strain on hospitals and clinics. Weak public health puts more pressure on the clinical side. Investing in public health is essential. It complements clinical reforms.
This has definitely been a deep dive. Ooh.
Yeah.
It's just so clear how incredibly complex and, well, tangled the U.S. healthcare system is. The scale of the challenges is enormous.
It really is. And the key takeaways are pretty stark, aren't they? We spend this enormous amount, yet our health outcomes often don't measure up to our peers. We face these huge interconnected problems with access, affordability, quality, efficiency, and equity. And layered over all of it is the massive impact of social determinants, things outside the clinic walls.
We've looked at quite a few potential paths for reform, from tweaking the ACA to bigger shifts like public options or value-based care. It really feels like any real lasting change needs a comprehensive, sustained effort, guided by those principles we talked about: universal coverage, affordability, equity, quality, efficiency.
Absolutely. Achieving meaningful reform won't be easy or quick. It's going to require real commitment to evidence, a willingness to tackle some deep-seated structural problems, and, frankly, collaboration among all the players involved.
Which brings us to a final thought for you, our listener, to chew on. Given the absolutely vast resources we pour into healthcare in the U.S., what fundamental shifts, maybe in our societal values, our priorities, what might be needed to truly transform this system into one that delivers high-quality care equitably and genuinely improves the health and well-being of all Americans?
That's the multi-trillion-dollar question, isn't it? Something to really think about.
Indeed. Thank you for joining us for this deep dive.